As you can see, both the IV starter and the patient are in a good position to one another, and all the supplies are set out and ready. The screen is set just to the left of the patient's arm, which allows the starter to visualize both the screen and the patient's arm when needed. As with other IV start methods, place the tourniquet several inches above the planned puncture site. Use about a quarter size amount of lubricant jelly to allow for seamless movement of your probe. Here you can see both a view of the IV starter and of the ultrasound screen itself. You can see that Jeff finds a vein and follows it up the arm. This will allow you to see if the vessel is straight, if there are any bifurcations, or if the vessel dives or changes depth or size drastically. It is also important to check if the vessel compresses easily to verify it being a vein versus an artery. On compression, an artery will remain pulsatile. At this point, you can decide which size needle and length of catheter is appropriate. If time allows, look thoroughly at your vessel options. The first vessel you find won't necessarily be the best. Although he found a vein that seems to be a good option, he continues to look at different areas to ensure there is not one that may be a better option. When you've selected a vessel, wipe away the excess lubricant and fully clean the area in which you will poke. Alcohol swabs come pre-packaged in the IV start kits, although CHG is also appropriate to use. After the skin is clean, use fresh lubricant. Ensure you know where the rest of your prepared supplies are before poking. You can see here that Jeff has found the same vessel he visualized before and verifies its path once again. Jeff centers the vessel on the screen using the center line setting. This aids in continued visualization and knowing where your vessel is. While you cannot see it in these views, it is important to note that Jeff exclusively looks at the screen after he makes contact with the skin. This will allow him to track his needle tip throughout the insertion. On the right, you can see the moment Jeff punctures the skin, both by the vessel compressing and by visualizing the small white dot at the top of the ultrasound screen. That is the very tip of his needle. Jeff then moves the probe forward only slightly with his left hand. On the screen, you can see the vessel reappear, with the tip of the needle now about halfway down to the top of the vessel. He repeats this process again until you can see the tip of his needle enter the top portion of the vessel. At this point, it is very tempting to take your eyes off the screen and look for blood return, or simply thread the catheter the rest of the way. Please do not do this. We utilize a walk-in method to guide the catheter into the vessel. This ensures you have not simply nicked the vessel wall or only partially punctured it. The walk-in process consists of moving the probe forward slightly until your needle tip disappears, and then moving the needle forward slightly until the tip is revisualized. The goal is to keep the needle tip in the center of the vessel as much as possible. You can walk the catheter all the way into the vessel if you'd like, although doing it 3 to 4 times should suffice. At this point, it is time to thread the remaining catheter. If your partner can visualize the catheter chamber easily, they can tell you if you have blood return, which is ideal and expected. That being said, there have been occasions that lube has slightly occluded the needle on insertion and blood has not freely flowed right away, even when you are in the vessel. Threading the catheter should feel easy. It is best to do this using a two-hand approach, which is often different from traditional IV insertion practice. Simply hold the needle steady with your dominant hand and place the ultrasound probe down with the other. Then use that hand to slide the catheter forward. This is beneficial as it lessens the chance of accidentally puncturing the needle through the other side of the vessel or causing unneeded manipulation. Do not force the catheter if you meet resistance. Simply return the catheter to its original place and visualize your needle tip on ultrasound once again to ensure placement of the tip of the needle. In this video, Jeff walked the IV all the way in and therefore did not need to advance the catheter further. As he withdrew the needle, you can see blood start to flow. To keep from making a mess, you can slow or halt blood flow by placing pressure above where the tip of the catheter is, not just above the hub. You want to occlude the actual vessel, not the catheter. At this point, you want to connect the pre-flushed T-connector and release your tourniquet. While Jeff does this independently, it is important to utilize your partner or another helper if possible during this part. Although there are some vessels this may not work, especially smaller ones, you can try to draw back to check for further blood return. Then flush saline through the vessel. Check for any fluid accumulation under the skin at or above the insertion site. Flushing should feel easy and should not cause pain to the patient. If it all feels good, go ahead and clamp the T-connector, clean the remaining lube off of the patient's skin, and prepare to dress it. Use the skin prep pad that comes in the IV start kits prior to placing a stat lock. At times, stat lock placement can kink the catheter, so it may be necessary to flush the line again at this point. It is personal preference on using tape prior to Tegaderm application, but please note the only tape permitted to be under the clear dressing is what is included in the stat lock package. To further stabilize the hub, you can place a small piece of folded gauze or a cotton ball underneath and add additional tape as needed. Congratulations, your IV insertion is complete.